All right, well, thank you guys for allowing me to be here. My name is Sam. I am the program director for Symmetry Recovery in Joliet. We have recently just opened in March. We are an opioid treatment program, so we offer services through medication such as Suboxone, Methadone, and Vivitrol. And then we also provide counseling, group therapy, IOP, PHP. We have a physician on site, a nurse on site, and a psychiatrist that visits our clinic every other week. So kind of a very comprehensive treatment program, and just something different that hasn't really been in Will County, Joliet. A little bit about myself. I'm from Joliet. I was born here. I live here now. I'm a licensed clinical social worker. I got my master's from Loyola in Chicago. I went to Northern Illinois for my bachelor's. Before working with Symmetry, I worked in the city doing some community outreach. I worked with older adults with severe mental illness. So a lot of trauma history, schizophrenia, bipolar disorders. So, and then I moved home, I had my son, and then got the job with Symmetry. So it kind of, everything just fell into place. So today I'm gonna talk with you guys about medicated assisted treatment. And I'm not sure, what you guys know about opioids. So I would kind of want to just start off, and I wasn't sure what to expect in terms of groups. So I think we could probably just do this as a group discussion rather than you guys breaking up. How about in the work that you guys do daily? Do you see opioid addiction, heroin addiction, anything, any type of substance use disorder? What are you guys seeing?
We're starting to get more and more cases where it's heroin or opioid addiction.
Okay. Got it. Are you working primarily in Joliet, surrounding Will County? Okay, so it's widespread. Okay.
Right.
Okay. Very interesting. What do you guys, what do you want to get out of this presentation? So questions that you have off the bat, so I can make sure that they're answered. Anything in particular?
I have a question.
Sure.
How do you know the level to give a client as far as methadone?
Mm-hmm.
What is the process of how you give someone methadone?
Mm-hmm.
Do they have to see therapy before they get it? How long are they on it? What are some of the symptoms that they'll get from it?
Sure.
My questions are just, what is it like?
In general.
The
Sure.
moment someone walks in to the moment
Definitely.
they walk out, what happens?
Yeah, and I'll definitely touch on that. So thank you for bringing that up for sure.
I know, in the recovery community, there's a big kind of controversy of using methadone, Suboxene, and that, and just
Sure.
going through recovery without that.
Yeah.
It's a big battle.
Definitely.
In the community.
A lot of 12-step focused groups don't believe that if you're using methadone and Suboxone on your recovery journey that you're technically sober. So that's a huge stigma. And I'll talk a little bit about that too. Did you have something?
That actually was what I was
Sure.
going to touch on. Just
Okay.
Because, a lot of people do. They say you're just going from one drug
Sure.
to another, and is it long term? Is this forever that they're
Sure.
on these things? Is this just it's the way to make it socially acceptable, where they're, instead of going on the street to get their hit, they're going to a clinic to get their hit?
Sure.
That's just kind of,
Sure.
just kind of know, I haven't had any cases with the parents that are, addiction. Addiction is the issue. But,
Okay.
you hear, so it's,
Sure.
it's a big deal.
Definitely.
But
Okay. Yeah, and it's definitely a couple slides in, we'll talk about it. Anything else?
Can you be a functioning opiate addict?
Can you be?
Mm-hmm.
Sure. Yeah, I think we would all be surprised to know who walks through my clinic doors. You'd be very surprised. It's not who you think. It's not the person who's standing on the corner of Jefferson and Larkin shaking a cup. It's a police officer and a nurse and a stay-at-home mom and a 19-year-old who went away to college and started using Xanax, moved on to marijuana, got a couple pills from a friend, and is now a full-blown opiate addict at 19 years old. It's very, it's not I just encourage you to think outside of the box. It's very eye-opening. Yeah.
How many seniors are you seeing with it?
I would say right now, probably like 4 to 6 over the age of like 62, like retirement age. Yeah.
I started out doctor prescribed.
Oh yeah. Hip replacement, knee surgery,
Happened to my mother
root canal. I mean, just
Just got my mother
a
off.
C-section.
because she had back pain.
Sure. Exactly.
What's the, like a opioid, the opioid suicide rate?
Yeah, I have all of it. And it's all Will County focused, so it's good that we're here, It's not, I present all different places. I present in Cook County, DuPage County, Kane County, Kendall. So, but the coroner's office in Will County is really good at getting that information out there. So I have it all, and I'll let you guys, we can kind of dig through that too. All right, let me get started. Okay, so today we're going to understand the 2 modalities of medicated assisted treatment, which are Suboxone and Methadone. Vivitrol is another option, but it's more long-term recovery focused, or usually used when someone's in recovery from an alcohol use disorder, so it's a little different. So we'll be able to distinguish between the 2 and then look at some countywide statistics to better understand the opioid epidemic on a community level. Okay, so what is medication-assisted treatment? So it's basically just the use of medications in combination with other therapies. So never is anyone walking into our clinic and strictly receiving medication and walking right back out the door. Absolutely not happening. We do not believe that medication is going to solve your problems, because you're going to end up right back where we started, and you have to be able to uncover some of those issues. Do either individual counseling or group therapy. We strongly encourage both. And at minimum, you have to meet with your counselor at least every 28 days and the physician every 28 days as well. And every time you dose, which is when you pick up your medication or take your medication, you see a nurse. She takes your vitals, talks with you about symptoms, how are you feeling, any withdrawal, are you feeling over-medicated? So there's always interaction with the provider, no matter what. So medications and counseling is the standard of care for a number of substance use disorders, including tobacco use disorders, alcohol use disorders, and obviously an opioid use disorder. Okay, so methadone. Methadone, I would say we prescribe methadone less frequently than we prescribe Suboxone. Suboxone is the newer drug. It's less easily diverted, which means it's less, likely to be abused. Suboxone doesn't have a lot of street value per se. You can't take, if you're taking Suboxone and you use an opioid, you will instantly become sick. You're instantly sick. I would say it's a medication that individuals who are really, 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 really ready for recovery utilize the most. Methadone is a little bit different. Methadone's been around since like 1930s. People have found ways to divert it. People have found ways to use it to get high. Methadone is kind of our last option. Some people take Suboxone and they have a reaction to it. Their body, it just doesn't sit well in their body. Their body chemistry rejects it. So we use methadone in those cases. It's just a different kind of drug. So methadone is long acting, but it's also used to treat chronic pain at the same time. So it is an opioid. Like, don't get me wrong, it's still an opioid. However, it's prescribed in a way that it's closely monitored. So if you come into our clinic and you want to receive methadone, you do an intake. You're typically with us for about 3 hours that day. You sit with a nurse, she takes your vitals, goes through a nursing assessment per se. You'll then see the physician assistant. She'll do a full history and physical. Any surgery you've ever had, obviously this is what a patient is going to tell us. We can't, we can dig as much as we want, but if someone is not going to open up, they're not going to open up. You also that day will meet with a counselor. So That's kind of helps to kind of uncover trauma, uncover, just clinical history, stuff that, how did this addiction start? Why did this start? And then after you meet with the counselor, you circle back to our nurse, and then we figure out as a team, as a treatment team, how to start dosing. So methadone has no top out. So you can take 260 milligrams of methadone and still be a functioning person. You could take 40 milligrams of methadone and still be a functioning person. It just depends on the severity of your use. So if you're injecting $300 of heroin a day, you're probably going to need upwards of 100 milligrams of methadone. It's just kind of how your body, it's going to react differently if it doesn't have what you need. So all doses start at 30. We always start at 30. You can only increase by 5, maybe every 4 or 5 days. So to get somebody to that 100 dose, you're with us for upwards of 8-9 weeks to get you comfortable. And
Inpatient?
no, it's all outpatient.
So, I guess why would you, is there a way you can start them higher and get them to come off of it, like to wean them off?
No.
Or they always start low?
They always start low because an average dose of methadone is about 60. So, you can be on 30, we'll bump you to 60 within 2 weeks, and you're good. And then we typically say, give it 90 days, give it 3 months, because not only are you just trying to kick this addiction, you're really trying to kick these behaviors. So you're still, thinking about drug seeking. You're still doing risky behaviors. You're still hanging around the same friends that you've been hanging around using with for the last 5-6 years. So we say, give us 90 days, and then we can make a plan of attack and figure out how this course of treatment is going to go for you. I've been with the company for about 1.5 years. I've seen patients in our other clinics. We have 5 other clinics in Illinois start and taper in about 10 to 12 months, I would say. It's not a quick fix by any means. It's not a miracle drug. It's not something that's going to take this away overnight. But it is something that's attainable, and we try and do it at a slow pace, because if you're too quick, think, if you're trying to lose 30 pounds and you lose it in 2 months by not eating, just up in a poor way, and you eat a McDonald's cheeseburger, then here we are, and we're 30 pounds, that it's all gone in a matter of 2 weeks, you know what I mean? So it's slow and steady. It has to be. It can't be something that's quick and ready to go, because it won't work, and that's proven. There are studies that show that the slower it goes and the more you're really focusing and working on yourself, the more attainable recovery is, and the more successful your recovery will be.
So after 90 days,
Mhm.
are you decreasing that amount?
It depends on the patient. So if the patient is like, okay, I'm at a stable dose, it's been 2 months since I've been at a stable dose. I am just working towards getting a job. I am, enrolled in school or something along those lines. We say, okay, so what do you want to do? This is all patient led. This is not us saying, okay, 90 days, all right, let's start getting you off of this. So it's really individualized. So it's hard to say, what really happens after 90 days, but we ask people to get someone to stay in treatment for 90 days is incredibly difficult, which I'm sure you guys know and you see daily working with, the clients that you're working with. To get someone to commit to anything for 90 days is huge. So I think from that, then we have to really say, okay, so now what do you want to do? What are we going to do from here? Is your goal to move out of your parents' basement, because that's kind of where you've ended up over the last couple of years? Okay, well then we need you to get a job. We got to start focusing on money, and money is a huge trigger for people. So here we are. What should we do? Our ultimate goal is to have someone substance free. That's our main goal. But it can be difficult. Patients become accustomed to feeling good, and anytime you start decreasing, there's going to be a little bit of symptoms that arise. You're going to feel a little bit of that withdrawal, because we're taking something away from you that's helping you feel good. So having a patient learn to be able to cope with that and to be able to use the skills that, you know, they're learning either in individual or group therapy is key, really.
So they can come in and say, I feel like this isn't working. If they come in and say, I feel like this isn't working, I want more, what do you guys do?
They're assessed by the doctor. You know, we use a CASA scale, which is like a clinical opiate withdrawal scale. So if you're coming in and you're saying this isn't working, but you're not showing me any withdrawal symptoms, we can't increase you. Like there's no clinical reason to increase you. If you come in and you're vomiting or you have a shake or you're sweating profusely, then we'll talk about it. But like I said, it'll only be 5 milligrams at a time. And to get somebody on a good dose can be really tricky too. You know, you have to really figure out what is appropriate for people. We've seen people who can go from 60 to 65, and at 65 they're perfect. You take them to 70 and they're a zombie. So then you got to bump them back down to 65. You know what I mean? But this all takes a week to be able. Once you put somebody up, you can't just take it right back away from them because then they're sick. Nobody likes to feel sick. And what's the first thought when you feel, if you're an opiate user and you feel sick, what do you want to do? You want to go use. That doesn't just get washed away from your brain.
This leads to a question, so what if they're double dipping? So if they're getting the methadone and Suboxene, I've had a case like that.
Sure.
And also the methadone does alter or does show up on the drops. So it's.
Yeah. So our patients are drug screened. Depending on stability, we could screen them every day that they walk through our door. So, you know, that's a big thing too. If you're still using, but you want an increase, it's not going to happen. If you're still showing positive for oxy and you have, 70 milligrams of methadone, we have to figure something out, because just because you're feeling sick doesn't give you an excuse to continue to use. So there's a federal requirement of 8 drug screens per year, but until someone's stable in our clinic, they're usually screened like once every 7 days, just depending, at least once a week until they're free of substances or are on a decent dose.
So can someone come in every day and get the methadone?
Mm-hmm.
And if they come in every day, they can't just come in, check in, and take the methadone and leave. They have to meet with someone.
Yeah. So methadone is federally regulated that it has to be dosed out of an opioid treatment program, which is our clinic, and you have to start dosing 6 days a week, meaning you are at my clinic 6 days a week and you take your dose in front of me. You have no take-homes other than Sunday because we're not open on Sundays, and which is, a very easy way to control the diversion of methadone, because it can be very easily diverted. To increase your privileges, you have to have negative urine drug screens for 90 days. So every 90 days, we can drop you 1 day. So you're with us, you're code 6, meaning you're picking up for 6 days a week. 90 days, you're clean, you're good, you've had all negative urine drug screens, you're really working the program, kudos, you don't have to pick up on Saturdays anymore. 90 more days pass, you're still doing really well, okay? You can take one of your weekdays away. So to get someone to pick up once a week, that's 270 days of treatment to be able to come 1 day a week. Typically, patients aren't even with us for that long. And if you're coming for treatment, that's discussed at the beginning. We're open very early in the morning. We open about 6:30, 7 o'clock. So people dose a lot of the times before they go to work. And we're open until about 3 o'clock in the afternoon. So depending on where a person's at, is kind of when they pick up, but that's known in the very beginning. It's a huge commitment. Can any of us say that we could be somewhere every day, 6 days a week, and have not miss it whatsoever? That's things come up, stuff comes up with your kids, or you're tired, you don't want to get out of bed at 6 o'clock to make it somewhere by 6:30. It's a huge commitment.
At what point, it's hard to wrap your head around this
Sure,
process,
sure.
right? Because it seems like you're swapping one thing for something that we say is okay. At what point do you call BS on it and go, you're making it every day here and doing all these things, but you're not taking it to another level? You haven't backed off any.
Sure.
When does that happen?
Again, that's individualized. I can tell you that we have a patient who has been with us, who was with us for about 5 months, still continuing use, still, using methadone, but also still having positive urine drug screens for other opiates. Not really working the program, missing visits with their counselor, not seeing the psychiatrist, just not 100% invested. Maybe here because mom, dad, girlfriend wanted you here, but you're just not 100%. So then you have to sit down and have that hard conversation, Why are you here? Well, because my parents want me here, and I can't stay at home if I'm not here. Okay, well, that's not a good enough reason. You have to be here to want to be here. It's tricky, though. I will be honest, because not every situation is the same. Maybe we have patients who, like I'm sure you guys see all the time, have severely traumatic history. So to try and deal with this trauma, to then deal with the chaotic living situation at home, to deal with all of these systems in one, it's hard to just expect that they're going to be perfectly clean and sober in 4 or 5 months. You know what I'm saying? It really depends on the person. And as a counselor, you're able to see that off the bat. If someone comes in and you could tell that they're a little hesitant, but they want to be there, that's one thing. If someone comes in and they're a little hesitant and their family wants them there, or they're only there because they're mandated to be there or court ordered or something like that, it's not a good enough reason. You have to do it because you want to do it.
So do you kick them out of the program then, when you realize this, that their heart's not in it and all that, or do you just keep working with it?
No, a discharge plan is then talked about. So we can either make referrals out, refer to a higher level of care. Maybe they need inpatient. Maybe they need a detox program. Maybe they need to totally be removed from the situation that they're in for 30 to 90 days. And, we can do that. We have relationships with people and other providers in the community to be able to do that. Maybe medication's not the solution to this problem. You know what I mean? So yeah, we definitely will figure out a discharge plan, but it's never like, okay, you're not following our rules, Friday you're done. You know what I mean? Like, we always have a transition plan at least in place.
And I've seen this with another facility where a parent has come in, gotten their dose, and is like, I gotta go, like I have to leave, leaves, and they do this every single day for 2 months straight. How do you regulate that?
Sure. We've done things where you're gonna meet with your counselor first and then you can dose. If you don't have time to meet with your counselor, then you don't have time to dose. Plain and simple. But we also get it, we've had patients who are like, I have my kids in the car, I gotta get them to school, it's 7:20 or something crazy. So we will work with people. We understand that people have lives outside of treatment. You have other responsibilities. But if we do see a pattern who somebody runs in, is expecting to just run out, okay, well, you have to see your counselor first, or at least sit down with the nurse for 5 minutes before you get your dose to kind of check in. Anybody, we're all clinically trained. Everybody on staff is clinically trained, so they could, essentially sit with anyone for a couple of minutes at least, just to make sure that things are okay, and that there's not another problem that we don't know about or situation being created during that time.
So when you said my kids in the car, so I'm so far removed from the drug scene, I have no idea. So does methadone cause you to have a high? Do you get a high from it?
Not
Or
if you're
it just takes the pain away.
It doesn't take the pain away, it takes the sickness away.
Okay.
And if you're on an appropriate dose, you should not feel any high from it. So there's no harm in a person leaving and driving, or leaving and having their kids in the car and getting them to school. However, you know, we've seen and heard of other stories or, you know, places that a person is over medicated and, you know, then they're leaving. So we have protocols in place for all that. So if we feel like someone comes in and is not, you know, in shape to drive, or is, you know, a little intoxicated or something along those lines, we have breathalyzers. We obviously have urine drug screens, but we also have the ability to say, we cannot let you leave here. So either we're going to call you an Uber and you can go home that way, or we're going to call the police and give them your license plate and tell them where you're heading, because it's not safe for anybody in this whole situation. Thankfully, our clinic has not encountered that, but I do know that, you know, our Naperville clinic has been open for 10 years. So they've encountered a lot. And, you know, that has to happen often.
Now, when you say sickness, are you talking about the withdrawal symptoms?
Yeah.
Okay.
Yeah. Yeah, I mean, we are by no means a pain clinic. We do not treat your pain. If you started using because of pain, you know, we are not saying that we're going to prescribe you enough medication to take your pain away. We're going to prescribe you medication to take your withdrawal symptoms away. So that's very different, and that's, you know, that's something that has to be made very clear, because a lot of patients come to us from having a knee surgery or are, you know, seeing a pain doctor at the time, and we are not a replacement for, you know, we're not a pain therapy replacement by any means.
Do you have walk-ins or referrals as clients, or is it a combination?
Yeah, it's a little bit of everything. So patients can walk in and be seen, but we do have a call center that we encourage patients to go through first, just so we can figure out insurance, or, you know, self-pay rates or anything like that. And they kind of do a brief screening first, just so we kind of know what's happening prior to a person walking through the door. You know, it's important to know when a person last used, because if you used 3 hours ago and you want Suboxone, we can't dose you. You have to be substance-free for at least 12 hours before getting medication. So that's difficult too, you know, because we have to be able to see what your withdrawal symptoms look like to see what level of dependence we're working with here. So if someone comes in and they've used 4 or 5 hours ago, you're not going to be near as sick and, you know, experiencing withdrawal symptoms as you would 12 hours later. And with the Vivitrol injection, you have to be free of substances for 7 to 10 days before receiving the injection, because it can cause severe, it induces withdrawal symptoms. Like, if you take the injection, you're intentionally making yourself sick, because we're putting medication in your body that is expelling everything, but it's, you know, it's difficult.
You mentioned insurance.
Mm-hmm.
What is the cost of that?
Sure. So it depends on insurance. And, you know, every plan is different. Some have out-of-network benefits, in-network benefits. It just, you know, some deductibles are higher than others. So it's really difficult to say what an average person would pay. But I will say that an average insured patient pays about $50 a month at our clinic.
Do you find that the insurance companies are easier to, it's not easier to work with, but are
Sure.
recognizing
Oh, yeah.
this
Mhm.
much more than in the past?
Yeah, there's actually a couple of new laws in place. I can't think of names currently, but it is to not be able to decline someone for services if they're looking, especially for opioid treatment, because the epidemic is so widespread.
I think you go into this later, so I'm sorry.
Yeah,
I don't
no,
mean
go
to-
ahead.
But I guess I've seen the documentaries and the movies and that, but I don't really understand how you would go from being addicted to painkillers or basically, then going from that to heroin, to having to get off heroin, then you would go from that onto methadone, or, I'm I just don't really understand how that all plays
Sure.
into each other.
So just briefly, I mean, okay, so I had a knee surgery. My doctor prescribed me 4 oxys a day for 2 weeks for pain. I take as prescribed. I'm good for my first week. My second week, my oxy's starting to slowly wear off a little sooner. So then I end up taking 6 oxys a day, and my prescription runs out on Thursday, and I don't see my doctor until Monday. So by this point, I'm dependent, and I could potentially be experiencing severe withdrawal symptoms by not having those medications on Thursday. So I call a friend and I say, hey, do you know anybody that has oxys or Norcos or anything I can get? And they say, sure, it's $50 a pill. I say, geez, I've been taking 6 pills a day, so I need to cover 4 days. So I need $1,000 to buy these pills. And I don't think I can afford it. But hey, I have something that you like. I have this thing, it's $10 a bag, and 4 bags will get you feeling perfect. Oh, okay. $40 times 4 is $160 versus $1,000 that I would pay for my prescription medication. You can snort heroin, you can inject heroin. So if I start off snorting, I'm like, oh, well, it's not that bad. I'm not a typical user because I'm not injecting. And then I realize that if I inject it, it gets into my bloodstream within 2 seconds. And I feel the high within 2 seconds. If I snort it, it takes a couple minutes for me to really feel it. So here we are, you've taken, $100, $150, and now you don't have to pay your copay at your doctor, or you don't have to deal with running out of your prescription early. You have to deal with your parents policing your meds, or your husband policing your meds, or whatever the case may be. And it's easy. You can just call someone and it's delivered to your door. You don't even have to leave most of the time. You know what I'm saying? Like, it's not as difficult to get it as you think it is, which is extremely terrifying, because I have a 14-month-old and an 8-year-old, and to think that, God Almighty, in 5 years we'll have a 13-year-old and he's gonna, it's terrifying. It really is, but it's not as difficult, and it's not as difficult to become dependent on it as you think it is either. It could
So in
be
your
a matter of a
scenario,
week.
you said it was a 2-week thing,
Yeah.
and that's what
And-
reality is, 2
Yeah.
weeks on
Mhm.
a painkiller?
That's
mind-boggling to me.
definitely. I have a nurse who is studying to be a nurse practitioner. She works for us. She had a C-section, was prescribed a week of Norco for a C-section, which is like, as a mom, it's like I don't want to say a routine, but it's, you can take some ibuprofen or some Tylenol 3 and like be okay. She was prescribed Norco. She took it for like 4 days, didn't take it her 5th day, and was profusely vomiting at home. Went to her doctor because she thought she had the flu, and her doctor was like, I bet you, she went to her PCP rather than her OB, and she said, I bet you formed a dependence in 4 days. And she's a nurse. I mean, she's taking it as prescribed. She's not overtaking it. She's not misusing. 4 days. And like that, I mean, her son is 10 months old. So that was it just happened.
So they get that, and they know once that script's up,
Mm-hmm.
you're not gonna get another script.
Yeah.
So then they go. and
They do that, or then they become, my mom is a pharmacist, so, I see this widespread. So then they start people are doctor shopping. So, okay, I know my doctor won't give me any more, but I'll make a appointment at my PCP. My OB won't give me any, so I'm gonna go see my PCP. Well, my PCP won't give me any, I'm gonna just find a new one.
Aren't those all linked now through?
There's it's a PMP, it's a prescription monitoring program, and it's all there, but it can take 10 days to show up in the system.
Or they're deliberately hurting themselves to get the thing.
Exactly, yeah.
I have a little fracture in my back, and it's been there for years. I just found out I had it. They prescribed me Oxy for the pain. I refused it, but he's like, well, he's like, normally you can just take like 1 pill, but I'll write on the bottom 4 pills per day. And I'm like,
Oh
what?
my
Yeah.
Yeah, so I didn't take it. I obviously left the prescription. I
And
was
if
like,
you
I'm
didn't know
not.
better, you would have taken it.
Correct. But he was like, that flat out what he told me. He was like, I'll just write 4 on there per day, so then you don't have to worry about running out. And I was like, are you kidding me?
Why,
I've gone
how is
years
this
with my
legal?
back.
How is this okay? I don't understand.
I wish I had the answer. I really do.
I mean, I can understand if somebody is terminally ill,
Sure,
you give them narcotics because they're dying, and why should they suffer?
of course.
But in this circumstance, why is this legal? I can't wrap my head around this.
They are working, like in Springfield, towards.
Yeah, and it's actually,
regulating, like, I think Dennis can only give out like 3 days worth
Yeah.
of room.
yeah. When I had my wisdom teeth removed, I was a senior in high school, so like 12 years ago or something, and he wrote me a script for Norco for like 10 days or something. I mean, I took one and I hallucinated. Thank God I hallucinated, because I don't know where I would be right now if I had just continued to take them and my body had not responded the way it did. But I mean, I was 18 years old with a script of Norco in my hand, which is like Skittles to high school kids nowadays.
I went to Florida. My mother had a health issue, and after visiting her in the hospital, I went back to her condo, and in her cabinet was 180 325s of the hydrocodone. Her back doctor had prescribed her because she has spinal stenosis,
Okay.
just the beginning of it. So she has a backache. So they give it to him to shut him up. She took 1 in the morning and then start martinis at 2 in the afternoon. So I had to get her off both the alcohol and
Sure.
the
Just-
hydrocodone in the hospital,
Yeah.
and it was miserable.
I can only imagine. So, I know that MAT is controversial, but in the grand scheme of things, when you think about it in like this perspective, I'd rather have our patients taking something that we regulate and that we're also utilizing other modes of therapy than out injecting a $40 bag of heroin laced with fentanyl and dying on the street. The medication that we're prescribing it's not going to kill someone. It's not going to harm them. It's, obviously it'll be work to get off of it. It'll be work, just like everything is though. And can you go cold turkey and be okay if you're using heroin and just go cold turkey and stop? Sure, you can, but it's miserable. And if once an addiction is in that full-blown state, it's very unlikely that someone is going to want to put their body through that, the pain of the withdrawal. Yeah, so let me kind of move on a little bit. Okay, so I already kind of mentioned that while taking Suboxone, if you also use an opioid, you will become sick from it. Buprenorphine is a blocker, so it sits on your receptor, and it closes it, so it doesn't allow any opioid to get in and to give you that high. So it sits on top of it, which can create a sickness. So usually when we are seeing someone who's taking Suboxone and is using, you're going to instantly know, because they come in and they're reporting all these symptoms, and then we'll give them a urine drug screen, and likely they've used. Suboxone, the Suboxone can be increased a little bit quicker than methadone, but it does have a max. So 24 milligrams is max for Suboxone, and you're typically starting on about 4. Average dose is about 16, and you can increase by either 2 or 4 every few days, I would say. So we can get someone to a very, a good dose of Suboxone in about a week, really. Yeah, but like I said, with Suboxone, you cannot have used for at least 12 hours prior to coming into our clinic. And depending on what you're using, it could even be longer. So if you're using, black tar heroin, 12 hours. But if you're using fentanyl, it pushes it up to about 18, 20 hours. It just kind of depends.
I'm sorry, I think I missed this, but
Sure.
what exactly, why would you choose this one over methadone?
There's less regulation around Suboxone. So it's harder to divert. So a Suboxone is a film. So it's a film. I wish I brought some samples. It's like it's orange flavored, and you put it underneath your tongue, and it dissolves into your body that way. So it's not a pill. You can't crush it up and, snort it or inject it or something along those lines. So it has essentially no street value. The street value is little to none on it. So we can get somebody to twice a week pickup for Suboxone quickly if they're following protocol. So if they're still meeting with their counselor and their physician and the psychiatrist. Suboxone can be prescribed at a doctor's office. You can walk into if your physician has a waiver, you can walk in and say, I have an opiate addiction, this is what I need, and he can write you a script for 30 days, and you could take it to your pharmacy and pick it up.
Okay, so it's so this is actually preventing the withdrawal symptoms, but it's causing you, if you're currently taking
You'll feel
any
sick.
other form of
Opioid.
opioid, you are going to feel sick instantly.
Exactly.
So you have to be sure that you're not going to use outside in order for this to be effective.
Exactly.
Okay.
Exactly. Okay, so Vivitrol is a once-a-month injection. Like I said before, you have to be free of substances, typically alcohol. We typically use this for individuals coming in with an alcohol use disorder. You have to be free for at least 7 days, depending on level of drinking. And it's a shot that you receive every 28 days. If you drink while you're taking the shot, it still is sitting on this receptor, so you won't feel any of the effects. However, that can be tricky because people will still use and still drink profusely, just like they were drinking, a week ago, and you can still overdose while having this injection in your body if you are continuing the habits that you formed, prior. So this also has to be something that is really used in combination with therapy, psychiatry. It's something that is closely monitored. So just because you're receiving an injection every 28 days does not mean we only see you every 28 days. We're checking in, especially after that injection. We like to see people, the next couple of days to make sure they're not having any side effects. And then we do really like to see people at least once a week after that, just to kind of touch base and to make sure that things are okay. But it is made very clear to the person, if you take this injection and you're still secretly drinking a fifth of vodka a day, you can really harm yourself. This doesn't make the vodka that you're drinking turn into water once it gets in your body. You're still drinking. You're just not going to feel the buzz from the liquor that you're consuming.
Are all three of these just as addictive?
No, what do you mean?
Is this addictive? Once they're doing these injections?
No.
It doesn't have any?
No, so we typically say try 3 injections, and then after that, see how long you can go without one. And if your cravings are still, a 2 out of 10 or something, that's manageable. If after 35 days your cravings are a 9 out of 10 or a 12 out of 10, then we say, okay, maybe we need one more injection, and then to continue building those coping skills or finding something that you can do. I would say we use Vivitrol for a lot of our older patients. So they're retired. And one woman I met with Monday, her coping skill was watching Lifetime. I mean, we gotta figure something out. You know what I mean? We have to figure something, because how depressed can one be after you watch Lifetime all day, every day? So, maybe we need to figure out some different coping skills. You know what I mean? But yeah, the goal for the Vivitrol injection especially is to be free of it after about 90 days. I would say between 3 and 6 months is ideal. to be off of it.
What would be the point of drinking when you're taking this if you don't feel the high, just because of habit?
Habit. Yeah, I think it's like, it's the compulsion of just doing it. You know, you're in your garage.
It's
Exactly.
social.
Yeah.
You still get the taste.
Yeah. Oh yeah, that doesn't
And
go
a lot of
away.
taste and smells are triggers.
Yeah, or you know, you're in the garage tinkering around and you crack a beer and it's just mindless. Yeah, you just do it. Yeah, I mean that, but again, that's, you know, that's addiction. You know, that's what we're kind of working with. Okay, so the ultimate goal of MAT is a full recovery, including the ability to live a self-directed life. We are really, really working to improve patient survival. So, you know, if we can help someone from not overdosing on heroin, that, you know, that's our main goal, or overdosing on prescription pills. Increase retention and treatment. So typically, like I said, retention and treatment is about 90 days. That's kind of our goal for people. But the longer that we keep you, the better your outcomes are. So the longer that you're enrolled in some type of therapy, whether that be individual or group, the better outcomes are shown. Obviously, to decrease illicit opiate use and other criminal activity among people with substance use disorders, you know, a lot of this risky behavior goes hand in hand. You're using, so you are stealing to you know, to feed that habit. You're using, so you are selling your body to feed that habit. You're using, so you're, you know, just doing a lot of other risky, extremely risky and dangerous behaviors. Obviously, to increase patients' ability to gain and maintain employment is huge. A lot of patients that we see come in unemployed, living, you know, had to move back home with parents, or living with a brother or sister. So independence is obviously a huge goal. And then improve birth outcomes among women who have substance use disorders and who are pregnant. So this is also kind of controversial. So we can prescribe medication to women who are pregnant and who are diagnosed with a substance use disorder. So if a woman is a chronic heroin user and she finds out she's 4 months pregnant, she can come and start receiving medication. Her child will be born with whichever methadone or Suboxone in their system. But you know, it's, would you rather have that or a child born with, you know, a fully addicted to heroin? It's kind of tricky. It's very closely monitored. The woman has to be working with a high-risk OB. We have to have communication with the high-risk OB. We have not seen that since opening in Joliet. And in all my training with the company, I've never seen a woman who is currently pregnant receiving treatment. We've seen people who have been pregnant and were still receiving treatment, but I've never seen anyone personally. But it can happen.
Do you require NA or AA, or are you the substitute for that?
Yeah, NA and AA, I mean, it's personal preference, like we kind of talked about a little bit earlier. If you disclose in NA or AA that you're utilizing medication-assisted treatment, people will, I don't want to say shun you, but it's not accepted.
Like you're cheating.
Yeah,
Yeah.
they're mean about it. They can get, there's some really, they can be mean about it. if
Yeah.
you're-
Yeah, it's just the way that the 12 steps work. So, you know, there are things now, so AA and NA, now there's Heroin Anonymous, which is, you know, MAT is accepted at Heroin Anonymous. There's other meetings now, like Smart Recovery meetings, which MAT is accepted, or Celebrate Recovery meetings where MAT is accepted. It's just kind of evolving with the times, I would say. NA and AA are very old school focused, you know, put you in the basement, lock you there for a few days, you're going to be fine kind of thing. Whereas, you know, I think it's proven that it's not always that cut and dry.
With that being said, then, do you require, does your company require them to go have an additional source, like NA or AA? I mean, or,
Outside of
or
our
AA,
care?
Yeah.
there's nothing required outside of our care. They are required to, to utilize our counseling, our psychiatry, our physician care, and depending, on, we have an IOP it's a morning a morning group from 9 to noon, Monday, Wednesday, Friday. So we know that's not, feasible for everybody. So we work with a couple partners in the community who do evening groups, but nothing's required. Okay. Okay, so a little bit about the stigma. So really, medication-assisted treatment is very underused, I think, due to a lot of the stigma that we've kind of talked about. It says here that people receiving MAT fell from 35% in 2002 to 28% in 2010. There are no recent studies. I'm assuming something will come out now because they're about 8 years apart. So I'm hoping there'll be something from 2018 to see where that number kind of lies now. But I will have to say that I really believe that it's becoming more of a norm. It's becoming more of something that is better utilized. We work a lot with police departments and fire departments, and I work very closely with like the Will County executives, the mayor of Joliet, to make it a little bit more common, or at least easily talked about. People aren't afraid to tell you that they're utilizing methadone or Suboxone. It's very surprising. I've made some relationships with people in the community, and the director of the Substance Use Coalition in Will County, her son is a recovering opiate addict, and he's been taking Suboxone for 2+ years, and she's unsure if he'll ever be okay to come off of it. And I think they've just become okay with that because in their eyes, he's not using heroin. He's not out, doing God only knows what for this drug. He's seeing a therapist and he's receiving Suboxone. And he's on a very low dose, but to come off of it is seemingly difficult for him. And that's just kind of where he's at right now. In maybe 6 months, things will be different. You never really know. But if you're functioning and you're maintaining a good life and you have a family and you have a successful career and you're utilizing this medication, what would we rather see happen? A person be totally off of it and their life be put back to square one, or stay on it and maintain and kind of thrive?
Do you see the stigma decreasing partly because I'm not comparing to, but assuming, this is just my assumption, but if they're using these drugs, possibly they are depressed or they have other mental issues going on. And since now it's a lot more common and
Sure.
That's a subject that people freely talk about, do you think that that's part of why the stigma probably might be decreasing, because people realize it's okay?
Sure.
We can talk about this, we can depression, we can talk about those schizophrenic and other issues, so
Sure.
we can also talk about
Substance issue.
Yeah.
Yeah, I think, I will honestly say that we see comorbidity amongst this issue more than anything. So it's not very common for someone to come in with strictly just an opiate addiction. Usually there's some trauma somewhere. There's some depression or anxiety or an underlying untreated bipolar disorder from, early high school years or something. Addiction and mental health go hand in hand. So I really think that, that's the importance of working with a counselor to kind of unravel all of that. But I really do think that has helped the stigma of, the disease of addiction become a little bit more easily talked about, a little bit more normal. Yeah.
Well, it used to be that it was a choice. People
Yeah.
made a choice.
Mhm.
And hopefully that's so much in
Yeah, definitely. Okay, so the number of patients in OTPs has almost doubled since 1993. However, an estimated 898,000 people use heroin, but only 20% of people are treated. So the percent of people being treated for prescription abuse is even lower. So we're talking about heroin addiction not being treated, and then prescription opiate use not being treated. So how do you feel like, as a community, we can expand services and get more people into treatment? Is it, because it sounds, like before talking with me, a lot of this was unknown to you guys. You had a lot of questions. You were trying to clarify a lot of things, which I think, is the purpose of doing these presentations. I think education is a huge piece, getting people to understand what the medications are. I think, and I will be honest, before working for Symetria, I've always been a social worker. I've always been a mental health professional, but I didn't know almost next to nothing about what's really going on. So I've had to educate myself a lot, and I've had to educate my loved ones too, because they ask, oh, where are you working? And I say an opioid treatment program, and they're like, what? Why? Why are you working with those people? So it's a huge education topic for sure. But how else do you guys think we can?
I know I've reached out, I think it's really important, in my community, in the Lincoln Way community, getting into high schools. I know I've reached out to the school
Sure.
boards, and even junior highs
Yeah.
level.
And I do have some statistics about the Lincoln, like New Lenox, Spokane, and Frankfurt that way.
And then when those statistics came out,
Yeah.
and,
Yeah.
they had an opioid summit.
Mhm.
When was it? It was, and I invited a couple of the mayors and the school board president, and no one showed up. And these kids are overdosing, and
Yeah.
the parents are losing kids, and they're wondering what's going on, and it needs to start at a young school
Definitely.
level.
Definitely.
A lot of the kids probably, I mean, I would think the kids probably are seeing their parents who might have been hurt or had an accident, they're like, oh, take these pills, and just keeps going, and then that's how they first get turned on to it.
Right. And how many times have we seen news articles where parents are found in cars with their kids in the car with them, who's 8, 9 years old, 3, 4 years old, So I think kids are seeing this at a extremely young age, whether it be in, that type of traumatic way, or just seeing drug paraphernalia in the house, or a parent not being present because they're high when they're, just at home eating dinner.
I had a case where the parents were heroin addicts, and the little girl would hang herself upside down on her bed and have blush come, because she wanted to see if that was the feeling that mommy or daddy were getting.
Yeah, that's
So,
heartbreaking.
At
Yeah.
9, 10 years old.
I feel like, am I the only one who feels like I'm in a bubble right now? I mean, I feel like this is very well hidden. That a lot of people are probably suffering that I'm not even realizing.
Sure.
Because I don't come across this at all. And I find it very hard to believe that if it's in New Lenox and if it's in Naperville,
Yeah.
it's not my next door neighbor. You know what I mean?
Sure.
It's very well hidden. People, am I the only one?
Yeah.
Are you guys seeing?
And I'll be,
I am the only one, okay.
and I'll be honest,
I don't see this.
I would say we have the least amount of patients at my clinic from Joliet. It's Plainfield, it's Frankfurt, it's New Lenox, it's Minooka, it's Shanahan, it's Romeoville, Bolingbrook, Elwood, places that you're like, what? My dad lives in Elwood. He lives in the middle of a cornfield. You know what I mean? Yeah. Or in our Naperville clinic has over 350 patients. Granted, they've been around for 10 years, but, they've seen, I think, 890 people walk through the door in Naperville.
Braidwood, Elwood,
Yeah.
and Wilmington have a very
Big
big
time.
problem.
Yeah, but their police department is spearheading it head on. Chief Ficarello is amazing, and he's just, He's done everything he possibly, they haven't had an overdose there in 2 years, when they went from having the highest per capita overdose rate in 2015 in Braidwood.
Well, they're all carrying Narcan too.
Sure. Then we also have clinics in Des Plaines and Highland Park, you know, up north in, you know, on the North Shore in the city, where you're like, you know, the cheapest home is 800 grand, and how is this an issue? It's exactly, it's a huge issue. And we have patients in, you know, we have a clinic in Lakeview in the city, and that's obviously a huge issue, and then Palos Heights. Yeah, I mean, it's not a disease that is, you know, it doesn't matter who you are, where you're from, what kind of family you came from, if you're male or female, black, white, brown, purple, blue, it doesn't matter.
How's your connection with the doctors? Because I feel that seems to be where
The
it's
issue lies.
focused, because they're the ones for years that maybe not realizing it, they're just trying to help their patients.
Yeah.
And they prescribe it, and then when it's gone, the feeling, you know, the addiction's there. How about your connection with the doctors?
You know, I mean, it's extremely tricky, because I could walk in. We are literally in our parking lot butts up to St. Joe's Hospital's parking lot. We're at Hames and Glenwood. I could walk into St. Joe's Hospital, and there could be 700 physicians in the hospital. How do you talk to every physician? How do you get in with every physician? And quite frankly,
You're getting a kickback from the drug companies.
and do you really think a doctor is going to listen to a social worker? And we've seen a lot of issues where, you know, it's a doctor of a certain sex, and then here I am, a 5'1" female. They pay me no mind. You know what I mean? It's just like, meh. I'll take your flyer. I'll take your brochure. I'll read it. Thank you. So that's an ever lying system. Our next goal is to get in with at least ER docs, because that's a lot of where we're seeing these scripts come from too. You know, you fall and you hurt your wrist. Here you go. You have a little pinch in your neck. Here you go. And what do? You know, especially if you're drug seeking, you go to the emergency room. So that's our next goal, is to get in with emergency docs. But it's tricky because a lot of doctors and hospitals are contracted employees. They're not. It's not. They don't have like a manual for every doctor that works at the hospital. From some most recent data, so I took data from 2015, which is the most recent, in 2005. Total overdose deaths from prescription and illicit drugs, which includes heroin, almost doubled in 10 years in the United States. So if you want to just break it down, for prescription drugs, went from, you know, about 18,000 to almost 30,000, and then opioids from about 18,000 to 33,000. Okay, so in 2018, as reported by the coroner of Will County, there have been 74 accidental overdoses, of which 51 cases were heroin and fentanyl related. These all have different breakdowns. So yeah, if you guys can, it's public knowledge, it's public information. You could simply Google Will County coroners, and it'll tell you, 21-year-old white female, heroin, fentanyl, cocaine were in their system when they were found to be dead. So this is increasingly alarming because it's October, and last year we had 85 people in Will County die of accidental drug overdoses. So we are expected to greatly exceed our numbers from last year. So I think as a community, we have to figure out how to stop this in the places that we're living in, you know, our communities that we don't feel like have this problem. So Joliet, which is the state's third largest city with a population around 150,000, had 36 heroin and fentanyl deaths last year, which is the most in any community in Will County. Other smaller cities and villages, including Shorewood, New Lenox, Mokina, were hardly immune. And I think I have some numbers here. So of the 85 deaths last year, 58% occurred outside of Joliet. 18 communities had a death, and at least 7 communities had at least 3 deaths. So a total of 25 people in their 20s died, and another 2 were teenagers. Joliet, New Lenox, Romeoville, Lockport, and Lamont all had multiple deaths of someone younger than 30. And then last year, there were at least 8 deaths among the Lincoln Way community, which is New Lenox, Mokina, Frankfort, Manhattan. So last year was the number of deaths was the highest that we've seen in I think it's 11 years or something like that. So it's increasing by the year. And so kind of as a little preface, so 2016 there were 78 deaths, 2015 there were 53 deaths. So between 2015, 2017, there was an increase of about 30 in 2 years.
But is it the amount of users, or is it because it's so cheap, or that it's so strong? I mean, is he say coming from China?
Sure.
Well, it's China, it's all of South America. I mean, you can get.
I know, but I'm
you can
saying,
set up-
have they skyrocketed for those reasons, or are we looking at?
Yeah, I think at least in the last 2 years, fentanyl has dramatically increased. So
Or the potency?
the potency. So kind of to put some, okay, so this is fentanyl here. So this is how much fentanyl, my fingernail is how much fentanyl it'll take to kill you. This is how much heroin it'll take to kill you. So if you have a little tiny speck mixed in with the bag of heroin that you bought, you have no clue what's in there. You have absolutely no idea. And if you're going to trust your drug dealer to tell you what's really in there, then that's a whole nother issue. But I think that's the huge thing. That's all of the studies as of late.
But why would the dealers, I mean, you don't want to kill your clients. I mean, why would they let that happen?
Because it hits them faster and it gives them a better high. So in communities where they are, and this is extremely morbid, in communities where people are finding out that people are dying because of fentanyl overdose, sales go up because people think that they can get higher from the drug that dealer is selling. And it just, the same amount of fentanyl that, affects me will affect you differently and you differently and you differently. It may kill me and you, but you guys are all just doing really great and having a great high. You never know. They could put the same exact amount in each, bag that they prepare, and it affects everybody differently.
Well,
You
maybe we
never
should-
know.
The government should sell it and regulate it.
I mean, fentanyl it's a prescription. It starts as it's a prescription that you're prescribed when you have a surgery. It's a drip, typically in an IV. Yeah.
Fentanyl is used
Yeah.
constantly.
Yeah.
You say that it's prescribed too?
Yeah.
It's-
Patches are prescribed. A fentanyl patch you can get it at your local pharmacy if you have a
But it's a
prescription.
rarity,
It's more common than you would think.
really.
I mean, if someone's at home on chemotherapy, they can get a fentanyl patch
Right, but
because
I'm
of the
saying-
pain that they're, sure, but if their 16-year-old son at home knows that mom has fentanyl patches in the cabinet and kind of, grabs a couple here and there and dispenses it to his friends, here we are.
But they're using the powdered fentanyl to cut the.
No, if you have a patch of fentanyl and you mix it with water, you put it on a little spoon and then you can inject it.
Okay, but I'm saying where they're cutting the heroin, when they're cutting the heroin with the fentanyl, that's powdered form.
No, not so say I have a patch of fentanyl. I cut a little piece of it off, mix it with water on a spoon, and then light it and burn it, and I get a rock. So then I take that rock and I crush it, and then I sprinkle it, like it's candy over whatever I'm preparing. So that's how it's kind of created. It's extremely frustrating because there's always going to be someone who tries something insane and figures out that it works.
Something new out there.
Yeah, that we don't know about, and
it's even better than fentanyl.
yeah. Okay. So I think that's I think now I want to kind of just questions. I mean, I know this has been really interactive, and I'm happy that you guys have been able to ask questions throughout, but is there anything that I didn't touch on that you guys still have questions about? Or there's a lot in the PowerPoint. You guys can read that, yourselves. I have business cards. You can email me. We can talk via email, but go ahead.
How is your drug drops different from a probation officer's drug drops or a caseworker's drug drops or another facility's drug drops?
Because we do like a 19 or 22 panel drop testing for everything. I know a girl who was working with us for group. She's a minor, so she was going to River Valley for probation. Her probation officer was only dropping her for marijuana because that's the only thing that she admitted to using. Every screen that showed up that we tested her for, there was ecstasy, there was cocaine. I mean, it's, everything. In her, but, right, exactly. So, it just, I don't know the justice system. That's something that I do not have much information on, but I do know that, and I assume funds are tight. So it's very expensive. It could be very expensive to run a 22 panel drug screen. If it's extra cost to do anything that's not routine, which is, marijuana, cocaine, ecstasy, opiates, whatever.
How quickly
Yeah.
do you get the results back?
Our lab is in San Diego, so we have to overnight it, typically within like 24 hours usually. But I mean, we can see it, so we can get confirmations day. We have so you pee in a cup, and then we flip the cup, and the cup, we can read it, but then we send it for confirmation. Sometimes there's a faint line, there's no line, but a person has admitted, so it's not always 100%, but we can pretty much know, within 2 minutes what's in someone's urine.
So typically when a mother goes in and has her baby,
Mhm.
and they find drugs in the baby system, do they not call DCFS right away? Like,
Yeah, they do.
That's what they
Yeah.
do. In the case where they're going to the clinic,
DCFS is still involved.
it is?
Mhm.
Okay.
Yeah.
I didn't know if
Because-
they got a free
They
pass
may be
because
on the case
they're.
because they have prescribed.
Yeah, it just depends. So if it's, and I also don't know much about DCFS or anything along those lines either, but it can be unfounded because the mom is at a clinic receiving treatment and is complying, but
Or if you're just prescribed
yeah,
oxy for back pain.
Yeah.
The baby will test positive
yeah.
and they'll open a DCFS case, but
Mhm.
it's a prescribed,
Mhm.
legally given med and
Mhm.
it'll be
Yeah.
closed.
Exactly.
One of my parents died.
Yeah.
That's-
Mhm.
That was part of the case.
Do you have
Yeah.
court-ordered clients?
Very rarely. We haven't seen much.
Do you take clients that are on public aid?
Mhm.
Yeah, so you do have some public aid opportunities,
Exactly. Yep.
and then they have a copay?
Yeah, but it just depends on MCOs and kind of, what branch they're falling under, Medicare, Medicaid, it depends. But there's some responsibility there.
Do you see patients particularly before inpatient treatment or after inpatient treatment?
Typically after. A lot of inpatients will refer to us as like a follow-up care. Or some patients are started on medication inpatient and then they need somewhere to continue it outpatient.
In terms of education
Mhm.
and I think that you made a good point, Kevin, it needs to get back in schools. Like,
For sure.
I remember growing up, there was DARE, there was.
Yeah.
I forget what other programs, I just remember went through DARE in elementary school, went through DARE in junior high.
Yeah.
And as far as I know, at least in the Joliet school districts, I don't see that anymore.
They're out of it. They're out of
They
it.
haven't showed
It wasn't
it.
very successful.
Yeah, but the
really.
Joliet school district doesn't do
It
DARE,
really
well,
wasn't-
Will County doesn't do DARE
Results
anymore.
weren't
Because the
very good.
research showed that it didn't work. It wasn't effective,
Mm.
so they stopped it.
But I think now,
Something.
with the amount, with the prevalence of this now and the many deaths that are going on, and it's in the news and all the social media, and, everybody can share everything. I would hope or think that a program like that
They
Yeah.
do talk about it in the high schools. They do, like, it's part of their health week,
Yeah.
and it's literally like I say week, but it's like a 6-week course. But I mean, let's be realistic, high school kids are gonna do what high school kids
Yeah.
are gonna do. I mean, they talk about it, and it all sounds great, but
Right.
it doesn't matter if they're already doing it or if it's an opioid, because a doctor prescribes those. So what's the big deal? 'Cause that's what I got told when I taught, like, what's the big deal? A doctor gave it out. The doctor can give it out, why can't I do it?
Yeah.
Or weed, it grows from the ground, why can't I do it?
Or
And
it's
what kind of
legal in
answer-
other states.
Yeah, right, like, what kind of answer can you give to that?
Well, and it is scary because like my son goes to, where we live in Joliet, but he goes to Plainfield High School. So, and he's told me in random conversations that there's actually kids that he goes to school with that he knows that sell drugs. He doesn't buy them, I make sure that's definite. But then, it's the same thing, he has many friends at Joliet West and Joliet Central, and, I mean, for teenagers to be able to, like, where are they getting the resources to find a drug dealer that's selling a teenager?
They're not
heroin?
finding a drug dealer. The drug dealer is finding them.
It's easy.
Your parents' medicine, your
Yeah.
grandparents'
Put the
medicine.
word out in the morning and during school, and by the end of school, they could have a.
And it's not too far from the schools on the corners where they're buying it.
Yeah, it's, I
don't-
mean,
and
it's
I don't
terrifying.
mean to sound like ignorant to the whole subject.
Sure.
I just,
Well,
it's hard to, like I said, it's hard to wrap your head
Clearly,
around.
I'm the most ignorant here. So, I think once you experience something, that's how I got it.
Yeah.
Through a case or personal, once you experience somebody, and this was through an OD, then you get like, you want to learn, you're like, this is crazy, and once you
Yeah.
start seeing this stuff, then it's just crazy how.
Well, in my high school where I work, they found that the security officer that was hired in the high school was the one that was saying.
Yeah.
Yeah.
I think it's hard for us to wrap our head around the world that kids actually live in these days. I mean, I know
Most
I'm
definitely.
older than you, but like social media and if you wanted to call a friend, the phone was in the living room.
Yeah.
And your parents were in the room because you were watching TV and you were like, hey, you want to come and play? There was no
Yeah.
way to get a hold of anybody that nobody knew about.
Yeah.
So we've created this world where it's so easy, and these kids, their parents are both working, nobody's home, they spend most of the day with their friends, and so that's where their whole social network is. And it just, we've made the mess that we're in. I don't know how we get out of it, because we got into it pretty quickly and pretty easily, and it's gonna be a lot harder to get away. I mean, you see, 8-year-old kids with a cell phone?
Yeah.
Who are they calling?
They don't call anyone. Nobody
Yeah.
calls.
They're texting.
Yeah, who are they texting? I don't know what they're doing.
Yeah.
We use our phones to call. They
I know,
don't.
yeah.
Well, a lot of times too, the high school students or the elementary, junior high, they get out like about 3-4 o'clock in the afternoon, okay? Parents are still working.
Yeah.
So within that time span, where do they go? If they're not involved in any sports or they don't have any other activity, where do they go?
I have a question. In the Will County area, Joliet, are you seeing any addiction or any people with the crocodile? Is that still in the area or is that gone?
It's gone. That
That's
was
good.
like,
What is that?
It's a
like
flesh
heroin,
eating
but
heroin.
It's cooked with gasoline and all the gasoline doesn't completely cook out, so when they inject it, they actually get a flesh eating disease.
yeah. That was, I think that was like about 8 years ago. Like that was a thing. Like that was,
Actually, 5 years
Oh,
ago,
was it
it's still in
5?
Will County.
okay,
Yeah.
yeah. No, we have, yeah,
Uh-huh.
yeah.
So that's gone
No,
then?
yeah.
Good.
Yeah.
I had a case, and the mom was in a methadone program. And in talking to her, her sense of it was that they didn't necessarily or wouldn't necessarily be encouraging her to move towards getting off of it.
Sure.
In my brain, I could be wrong about, I'm wrong about this, I'm sure, but, in my brain, I saw it as a treatment to move eventually towards
Totally.
not being on a substance. Her sense of it was that, and hearing you talk about the longer they are involved in the program, the more likely their success, but her sense of it was like, she she would probably be on methadone.
Forever,
That was
or,
her sense.
you know,
I mean,
for a long time.
Yeah, and it was, for the best that we could see, cooperating with the program, but, you know, in my kind of asking about, you know, do they step you down off that methadone, and how does that work? And, you know, just talking to her about it.
Yeah.
You know, no, she wasn't being stepped down, no, that wasn't happening, no, that didn't look to be happening soon.
Yeah.
You know, kind of, and her sense of it was that this would be, there was not like a point at which she thought that it would be over or done, or
yeah.
that she would step down, or however that would work. And that was really interesting to me, because
Yeah.
I didn't see it as I didn't view it as the rest of your life here on methadone.
You know, it's very individualized. Like I said that story about the woman from Will County, and her son is on Suboxene, and he and his wife or girlfriend or something, like, they very well may be on Suboxene for 10 years before they're ever ready to decrease. There have been programs that are strictly methadone focused that are not, how do I say? I don't want to bash other programs, but there have been other programs where there is no end in sight, and it's just, this is what you're doing. This is easy. This is going to keep you good. You're going to be able to, you know, you're going to just do this forever. However, there are plenty of studies that show that, you know, the effects that the effects that taking any medication for, you know, long term has on your body, has on your liver, has on your kidneys, and it's not something that's meant to be taken forever. However, methadone clinics have been around for 40 years, and that's kind of the stigma associated with that. Not all methadone clinics offer counseling or group therapy, or, you know what I mean? That's something that we pride ourselves in not being. You know, we do not refer to ourselves as a methadone clinic. We're an opioid treatment program. We're a program, and you're going to work it, or it's not going to be successful. We're not a clinic. You know, this is not just somewhere that you come and pick up your meds and run away from.
Like, for most of your clients, patients, the ultimate goal would be to eventually be off whatever their medication treatment is.
Yeah,
But the time of that may...
Yeah, is right now, so we've been open since March. I have 4 patients who have been with us since, like, that first 30 days of being open. There's 4 of them right now who are tapering. And it's been 6, you know, we're at about 7 months being open. We opened March 15th. So, you know, that's about appropriate, you know, and they're decreasing they're on Suboxene. 3 of them are on Suboxene, 1 is on methadone, and they're decreasing. Suboxene is decreasing 2 milligrams like every 2 weeks. So if you're on 12, you know, the tapers also takes a little bit. It's not something that you go from 12 to 6, because that's going to cause a whole bunch of problems. And with methadone, you do the same as you would increase. You decrease by 5. So if you're on a higher dose, it's going to take you longer to taper off of. But it's important not to taper too quickly, because then, you know, you kind of stir the pot, and things aren't addressed the way that they should be.
You might be starting all over from scratch
Exactly.
again.
Well,
Yeah.
You have to deal with psychological addiction too.
Totally.
And that's
100%.
a big draw that a lot of people don't realize, that psychological addiction is much greater than the physical addiction.
Yeah, I think just changing behaviors is one thing. You know, it took, with one of our patients, it took us almost 4 months for him to delete his drug dealer's phone number out of his phone. He could not physically do it. It would be a full panic. I mean, shaking, tears, almost on the verge of vomiting, before he could simply delete a phone number from his phone. And, you know, and that's reality. Like, that's what we're working with. This isn't just, you know, don't call this. It's a whole behavior game, you know, like it's or psychological. Any other questions?
So if they stop, your patients stop the medication, can they continue to come to you for the therapy, the behavior change, the
Definitely. Yeah, we do offer what's called aftercare. So it's, after medication is done, or after you're done with your group, because group therapy is not meant to be forever either. So after you're done with group therapy, we want you to just do individual therapy. Yeah, so we do have aftercare programs. And you don't have to be taking medication to receive, to be in group. That's not required. We have 2 people in group right now who are on no medication. But our
Pay to go, like, if you're not receiving any medication, you still have to
Yeah,
pay the
for the
monthly
group.
to go to.
Yeah, and that's kind of a separate fee, but
Yeah.
yeah. Any other questions? Thank you guys. This has been good. I mean, this was great. Thank you.